The first speaker is Professor Magdy. He is a well-known professor of hematology and well-known in hemophilia, and he will present a talk on Egyptian prophylaxis protocol in Egypt.
Thank you, Prof Magdy. طيبة. كل سنة وانتم طيبين جميعا بمناسبة يوم الثلاثين. Maybe this is not a new talk. We are discussing this project since 3 years for the time being, trying to start and advocate for Egyptian prophylaxis in severe hemophilia. As we all know, the cycle of joint damage in hemophilia, where hemorrhage causes synovial inflammation, and recurrent hemochromatosis will cause synovial hypertrophy, synovial impingement, which will ultimately destroy the joint and results in severe incapacitation of patients with severe hemophilia. Probably since the 60s, Sweden started a sort of prophylaxis protocol, even with the cryo acetate at this time. And this is a highlight of what is the outcome of the different modalities of therapy in severe hemophilia. So if we start primary prophylaxis or early secondary prophylaxis, we can enable practically normal psychosocial development without overprotection, meaning that we allow the patient for a normal life. Late secondary prophylaxis is as good as in many situations. Secondary prophylaxis in adolescents and adults will only keep the status quo according to the degree of joint damage and the time of the start of the prophylaxis. Then you have the surgical short-term prophylaxis and on-demand. And probably I will go through the outcomes during the presentation. So the agenda is to define prophylaxis, the history of prophylaxis, the evidence of superiority over on-demand therapy, protocols of prophylaxis for children with hemophilia A, and now we have 15-month prophylaxis experience in our center, and some conclusions. So the definition of prophylaxis is regular injection of clotting factor concentrate at a specific time interval to maintain the clotting factor trough level sufficient to prevent spontaneous joint bleeds in patients with severe hemophilia A, which is usually about 2% as a residual factor at the trough level. There are so many retrospective cohort studies which show that prophylaxis can improve the quality of life in patients with severe hemophilia A or severe hemophilia B. Yet the criticism was the lack of controlled studies. The evidence, one of the evidences that show that the prophylaxis is superior to on-demand is this study that was published by Vandenberg in hemophilia, and in which she compared the on-demand treatment in France at this time, which was, in the late 90s, early 2000s, between the intermediate dose prophylaxis protocol in Netherlands and the high dose prophylaxis in Sweden. If we look to two important things, one is that the dose of on-demand in France was almost equivalent to the dose of intermediate dose prophylaxis in Netherlands, and that this dose was almost half the dose used by the Swedish protocol. Yet the outcome, there is a significant difference between on-demand, which uses the same amount of clotting factor concentrate, compared to the intermediate dose prophylaxis, while the difference between using intermediate dose and large dose was not that much. So this opens the lines that maybe we can use less amounts of factor VIII to start prophylaxis. Two recent studies, the North American randomized controlled study by Marco Johnson and the interim results of prospective study of Alessandro Gingiri and his colleagues showed in controlled studies superiority of prophylaxis. In that, it reduces the number of joint and soft tissue bleeds, reduces days of immobility and absence from school, and preserves joints as evidenced clinically and radiology, which means that prophylaxis can improve the quality of life of patients with hemophilia. So what are the stages of the prophylaxis? The initial introduction of prophylaxis to a child during the first 3 years of life. This is one stage. The establishment of a regular pattern of factor administration in an older child. Then, when the child grows, we need to modify the prophylaxis to compensate for enhanced physical activity in the teenage years. And then, when he reaches the adulthood, there is a potential for modification to reduce intensity of prophylaxis in phenotypically mild cases with severe hemophilia. When we compare the prophylaxis in the Swedish and the Dutch, we find that the Swedish usually starts the prophylaxis at 1 to 2 years of age. They infuse factor VIII a minimum of 3 times per week, and now they are even thinking of smaller dose daily infusion of factor VIII. High dose with an average of 6,000 international units per kg per year, which is a huge sum of money consumed for these days. The Dutch starts after 1 to 2 joint bleeds, meaning that the age of start is 3.9 years, and this is a huge saving. 2 years of saving or consumption of factor VIII. Tailored protocol according to phenotype severity, and the intermediate dose factor VIII average is around 3,000 international units per kg per year. If we compare the outcome of the two protocols based on the experiences, we find that in the Netherlands, the age at start of first prophylaxis, the mean was 5.4 years, while in Sweden was 3.1 years. The dose is 35 units per kg per week. Here it's 82 units per kg per week. The age at evaluation of the cohorts was 22 and 17 years. Joint bleeds per year were 2.5, is 0.5. Patient without joint bleeds 5%. Of course, in the Switch is 25%. But the outcome, the clinical score is not much of a difference, and the Peterson radiological score is not much of a difference. So this is an important thing when we are planning our prophylaxis protocol. A third protocol is the Canadian prophylaxis protocol, which is tailored increase of factor VIII dosing depending on the breakthrough bleeds. Concentrate dose of 50 international per kg once weekly and escalated through 2 steps to prophylaxis at a dose of 25 international units per kg factor VIII on alternate days. The analysis show that this protocol as well is very good and very efficient, but the point is that with the age, they evaluated eventually to 3 doses as the switch protocol. How do we evaluate our prophylaxis protocols? Short-term outcome, the annual number of joint bleeds. Long-term is the clinical score and the radiological score, the Gilbert and the Peterson. And of course, we need to calculate the treatment cost and the pharmacoeconomics, means how much do we spend and how much do we gain for the patient in terms of quality of life and integration into the society. I will give a highlight of the outcome of the Dutch protocol that started since 1969, where they tailored according to bleeding patterns, start after first joint bleed, dose increase in case of bleeding, and stop if dose is low and bleeds are. The earlier the start is more effective before the first joint bleed, and the dose number of bleeds will determine the trough level on which we base the dose. If you look to 3 cohorts, because they evolved in the period of time, and the evaluation was for these 3 cohorts, those who started prophylaxis before 3 years, those who started between 3 and 6 years, and those who started after 6 years. It is evident that the earlier you start, the outcome from the Peterson and the score and the 0 Peterson change is much better or much in favor of starting before 3 years than in other groups. So the conclusion is that the onset of joint bleeds varies widely between 0.2 years to 5.8 years according to the bleeds. At the age of 20 years, plus 8% in Peterson score per year delay after first joint bleed. So the earlier we start, the outcome will be better, and the optimum effect if it started before the third joint bleed. The protocol is now running as follows. If the kid is 10 to 12 kilograms, they start with 500 international units once per week, then 500 twice weekly if there is one joint bleed, and then 253 times if there is another joint bleed. Of course, they increase the doses if the body weight of the child is taken. So in conclusion of the Dutch prophylaxis, start early after 1 or 2 joint bleeds and consider starting as once per week, those according to the bleeds, and discontinuing only in adults, only if mild phenotype, and you have to monitor the outcome. So this, we had, maybe I'm not showing this in the slides, but we had a multi-center study across 9 countries in developing countries, where we evaluated the outcome of the treatment in these different countries as is. And the range of the use of clotting factor concentrates was ranging like from India as 100 units per kg to Egypt about 275 units per kg to countries like Argentina and Iran where they use close to 1,500 units per kg per year. But the outcome on the on-demand was not varied. With the very low dose or with the intermediate dose was not varied. And this led us to think, what about starting any sort of prophylaxis? If this can change the outcome of the disease. So we discussed since 2006 a low-dose prophylaxis. And we discussed this here since, I think, 2009 with all the centers that we need to think of a low-dose prophylaxis protocol based on the hypothesis that if we can reach 1,000 units per kg per year, maybe the outcome can be better. We can afford to do this because we do not follow any prophylaxis protocols, while in European countries or developed countries, they don't have this luxury as they are bound by their protocols so that they cannot go to low doses and to explore if this can be effective or not. Anyway, after several meetings, we agreed to have Egyptian prophylaxis consensus, which includes inclusion criteria, age, duration, dose, and treatment of breakthrough bleeds. And we agreed that the inclusion severe hemophilia A below 1% irrespective of bleeding symptoms or below 2% with repeated attacks of spontaneous joint or muscle bleeds, because sometimes in our labs we find difficulty to determine below 1%. Sometimes we have the severe hemophilics diagnosed as 1.5, 1.2%, but the phenotype shows that he is severe. Exclusion history of adverse drug reaction or hypersensitivity, HCV positive patients, or we decided to include even HCV positive patients, and of course if the patient has the inhibitor, this is an exclusion criteria. We thought of 2 to 4 years age of start, minimum age 2 years in a patient who had 2 bleeds in an index joint, means 2 subsequent bleeds in one joint, and maximum age 4 years with no joint bleeds or 1 bleed in an index joint. We decided that the prophylaxis dose is 20 international unit factor 8 per kg once weekly. If breakthrough bleed increased to 20 international unit factor 8 per kg to be given as twice or 3 times per week. With breakthrough, we treat breakthrough bleeds minor as 25 international unit per kg and major as 50 international unit, and we resume prophylaxis after control of the bleed. What doses at older age? Because we said we are starting for 3, and if you have enough money to expand to 5 years to see the outcome. At this time, before the revolution, we said that we will enroll patients within 6 months, starting from January 2011 or earlier, the time of the revolution, and prophylaxis for 3 years with possible extension to 5 years. We said we will think of tailoring the prophylaxis based on the pharmacokinetic studies or based on clinical phenotype. What does this mean? If we look into this was an infusion of a group of severe hemophilia A with our new solvent detergent cryoprecipitate, where we have the basal level below 1%, and we infused like 40 international units per kg, and we studied the pharmacokinetic of the factor A over 36 hours. So the mean after 36 hours, we had like 11.4% residual factor A level, but in some we have quite high, like 14, 13 residual. So the behavior between one patient to the other is different. So if we study the pharmacokinetics of each child, we may decide what is the frequency of infusions. And if we combine this with the clinical severity or the phenotype, then we can probably decide on the optimum dose that we use in the prophylaxis. As I said, the clinical phenotype is another determinant. Some will have mild phenotype, they are not frequent bleeders, and some, even if they are severe, they have more frequent bleeds. The decision of 2 to 4 years was based on two things, economy and the venous access. Because at earlier age, we probably will need, with this frequency of infusions, to insert indwelling catheter, which is both a danger as of infection and thrombosis. So we thought that the best is to start 2 to 4 years when the venous access is easy. And upon once dose per week, this is also easy for the kids and the parents. Planning the infusions. Factor VIII infusions should be planned on days of intensive activity. So if the kid goes to school, what is the day of intensive activity? Let's say the day of sports. We make our infusion on the day of sports, so that the maximum effect of the infusion is on the day of the maximum activity. Morning infusions are best to cover the activities with high factor VIII blood levels. This is the indwelling catheter and the ways. Some of these of our patients may have, through their insurance program, the ability to have the product or the factor at their homes. And they will persuade the prophylaxis as in-home therapy. So in this, we have to make sure of several things. That the patients have competent venous access, ensuring an available supply of clotting factor, concentrate, and other disposable equipment, knowledge of appropriate storage and safe disposal of used items, detailed data collection, knowledge of symptoms of specific spontaneous and traumatic bleeds, and their necessary treatment. Because these kids, if they are new, if they did not experience bleeds, if they are only diagnosed as having severe hemophilia A, they may not have experience of what's a bleed like. So we have to educate them and their families as well. Knowledge of how and when to seek professional advice from hemophilia specialists, not to be on their own for all the time. The monitoring of the prophylaxis at initiation, basal level of factor VIII, screening for inhibitors, recovery pharmacokinetic study, clinical and radiological evaluation of muscle and joints, because this will be the monitor as well at the end of the protocol. During first 50 exposure days, recording of infusions, inhibitor screening every 4th exposure day for the first 20 exposure days, subsequent inhibitor screening every 3 months, for when poor response to factor VIII infusion is reported, and recording of any breakthrough bleeds. After 50 exposure days, which is probably the time when this patient is most probably will not develop inhibitors, the regular inhibitor screen is every 6 months, recording of breakthrough bleeds, prompt and effective treatment of any breakthrough bleed according to approved guidelines, regular visits to the hemophilia center for clinical evaluation and factor VIII dose adjustment, and full surgical prophylaxis program in case of surgical intervention. far, I will give some of our experience in our center. We have, so far, we enrolled 4 patients on coagulate. Their age was like 2.5 years. They are on once dose prophylaxis. Now they have passed 15-month period. None of them developed inhibitors, and only one gave one breakthrough bleed through the 15-month period. The kids are very active. They have no joint bleeds. They had probably 1 or 2 joint bleeds before being enrolled into the maybe this boy was in the World Failure Day, and he's 3.5 years now. وكان حافظ آية الرحمن بالكامل وقالها في يوم. So it's magnificent that you see that all these families are poor families, and they are very punctual. They never missed one day of infusion, even during the turbulence of the revolution, which shows how much the families are keen if they see that this can be of benefit for their kids. I give to Elite another example to Elite secondary prophylaxis. This boy is the hyperdynamic boy. He was born in 2006. He was on demand until October 2010. During this period, he had bleeding at circumcision. 2007, left knee, buttock bleeding, left shoulder bleeding. 2008, scalp bleeding, knee bleeding, ankle bleed, dorsal foot bleed. 2009, foot bleed, left knee bleed 2 times, gum bleed. I mean, a history of several severe bleedings until he started his prophylaxis in 2010. Since then, he never had a major joint bleed. He only has a big toe bleed because he all the time plays football. And this is not very well known that the ankle bleed is more common in the patients on prophylaxis because they are active with the sports and particularly football. This is the boy. I think this photo was since 5 or 6 months, but it shows that he has perfect joints. Since we started the production of our new product, which is the solvent detergent cryoprecipitate, we started to enroll also patients on this product. We took the older age group between 3 and 6 years. We are keeping the dose. These are active boys, so they go to school, they play. So once a week dose is not enough, so we decided on giving them 2 doses a week. Each is 20 international units. 2 patients experienced 2 mild breakthrough bleeds through 6 months since the enrollment. 3rd patient reported no breakthrough bleed during the whole period and no inhibitor development. On the same product for patients, since I believe more than 1 year, or other patients on ad hoc prophylaxis, they use between 500 to 1,000 international units per week. And they are quite heavy. The weights are known, most of them, at least 70 to 100 kilograms. We are now more than 1 year, no spontaneous bleeding episodes in 3 patients, reduced frequency of bleeding episodes in the 4th patient. The more important that the 4 patients report the following: no or reduced spontaneous bleeding episodes, improved mobility and reduced pain, decreased periods of absence from work with more productivity, improved psychosocial status, no inhibitor development, and no adverse events from the SD crash. So even in the old age, a once a week dose can make a lot of change for these patients. So in conclusion, prophylaxis is a gold standard for lifelong management of hemophiliacs because it maintains the musculoskeletal function, full psychosocial integration, and complete functional independence. Pharmacoeconomic studies to compare low-dose prophylaxis Egyptian protocol to current Egyptian standard of care, which is episodic treatment or treatment on demand at the end of 3 years. We probably will take a cohort of those patients of the same age who are on demand and compare the outcome within 3 years. So it can give us if this is superior to our standard protocols or not. At the end, I would like to thank those who are involved in our center in the work. And thank you very much.
Thank you very much to Dr. Ekiaby for this excellent presentation and And you like your prophylaxis. And one question.
Yeah. What about the financial aspect of this prophylactic regimen? Because it is very good. Financially, how much it costs?
Yeah. We have two types of patients. Patients kept on cogenate. We are sponsoring the whole study. The cogenate patient costs like, at the current dose, £70,000 per year.
70,000
Yes. On the LV crime, you will have, I think, half of the price.
And it gives the same results?
We are following. It's giving the same results so far.
So, same results for prophylaxis?
Yes.
So, how much it will cost in the crime?
Yeah, with the dose we are using, it will be 50% of the cushion.
Oh, yeah, 35,000.
لا بس مش كتير على العيان ده، يعني مفيد، احنا عايزين نعمل له بروفلاكسس لانه يعني ناجح جدا البروفلاكسس. احنا قلنا الحقيقه جمعنا كتير واول الثوره قلنا الكلام ده.